Good morning. Thanks Dr. Shaji for involving me in the IC. So let's go to the posterior lamellar keratoplasty after that wonderful talk. Now I'll be discussing about the DSEK and DSAEK and then we'll continue with the DMAC. So a little bit of history. In the early 1950s, it was Jose Baraka, like in many other techniques. He is the first one who tried out this. He described a technique in which he successfully transplanted a lamellae of posterior cornea under a manually hinged flap. And in 1998, Culbertson actually refined it a little bit by doing it under a elastic microkeratome created flap. But it was Mellis in 1998 who actually devised this, implanted into a round pocket actually. And then he refined further, finally stripping the DM and then giving the term DSEK for that. So it was Mellis who we are all indebted to for the DSEKs actually. And initially the donor lamellae, it was created with a manual dissection. But later they used microkeratome as we know, and then the term DSAEK came into Now, for the surgical technique of DSEK, there is, I'll be dividing it into different sections actually. The preparation of the donor tissue and the preparation of the recipient, the descendant membrane stripping and placement of the graft in the post-operative care. So the preparation of the donor corneal tissue, as you know, it is very important for this step actually. It's either done by the operating surgeon or the trained technician in the eye bank. This is the usual artificial anterior chamber I use actually. Parents, you should know the different sections of that, and you should be familiarized with the chamber actually. And also you have guarded knives, and lamellar dissectors. Now, as I said, you should be very familiar with the different parts, like the pedestal and the different parts of the chamber, and then you can see you have to lock and unlock it before actually doing the manual preparation actually. Right? You can put a little bit of saline there and then put the cornea, lock it again. This is like doing a manual DALK on a donor tissue, but it's a little more easier because it is donor tissue and got right. And then you can make the initial groove with the guard knife. Usually you go for 350 or 400 depending on the packing. And then you make the initial entry with the crescent and continue this with the lamellar dissector. Make sure that you don't cut through actually, and try to be a uniform layer actually. And removing it is also you have to be careful so that you don't dimple it, but you will have a little bit of that invariably, right? And then you do the usual trephining as usual, put it under trephine Teflon block, and then once you get that, you separate it and put a saline so that you will be sure about that separation. Now the same thing, usually we don't do this that much. You can do it with a microkeratome, that is DSAEK, and then you put the button back for this thing. And then the preparation of the recipient cornea, you have to make a scleral tunnel, 6 mm scleral tunnel, and then 2 paracentesis, and through 1 paracentesis with the reverse Sinski you can make it. So fast forward, we have to be a little slow than that. And there shouldn't be any edges or flaps actually. It's better to just remove it even after this by washing. You can do an inferior PI either through the same paracentesis, or you can make another paracentesis and do inferior PI. And then wash all of the OVDs after that. You have to have a clear anterior chamber for the graft. Now for the placement of the graft, there are multiple graft insertion devices like this one. You have a coronet or a Tan's glide. I was fortunate to use that once. And Buzin's glide actually, you need a separate paracentesis for pulling the graft inside the anterior chamber, but these are all prohibitively expensive. So I think most of us are using this. This is with just a normal 26 gauge needle, you can just push it in. It's as simple as that. But you have to put the bubble inside, bubble it, and then after the suturing you can center it by slightly sliding it to the center. This would be a good initial thing for the further DMAX and all this stuff. Post-operative care, the patient is examined in the slit lamp up to 1 or 2 hours after the procedure and is advised to remain face up overnight as much as possible to facilitate the graft attachment. Topical steroids. POD1, if the graft is attached, previously edematous cornea starts clearing. It's not like fully clear, but it starts clearing. And it will usually take around 2 to 3 weeks to clear. And if the graft is totally detached, it's reattached using air or expansile gases, depending on the availability. And rebubbling can be done even after 3 to 5 days, they say. So this is the largest study actually, which is done by Price, obviously. I mean, this is a 15-year outcomes, and after 15 years, they say the probability of graft failure was around 7% at 5 years, 16% at 10 years, 23% at 15 years. So it's been proven very well that long-term visual rehabilitation and graft attachment is very good with DSEKs. Even though DMAC has almost it's a superior procedure, but still there are a lot of areas where we still can use this, and I feel that should be the first line of this thing for any anything.